So, dear participants, my name is Dr. Julia Zając, and I have a great pleasure to welcome you at the 5th EuroBloodNet's Topic on Focus Cutaneous Lymphoma webinar. Before we start, please mute your microphone and switch off your cameras to maintain better streaming quality. And please make sure you have entered your full name and surname in WebEx because it's very important for receiving the educational points after attending the whole cycle of webinars. Of course, if you have any questions about the presentation, please write it in the chat. Of course, dear audience, please welcome with me today's two speakers, Professor Evangelia Papadavid and Professor Pietro Quaglino, who will tell us about aggressive T-cell lymphomas. Evangelia Papadavid is a professor in dermatology venerology and the chair of the second department of dermatology venerology at Tikhon General Hospital at the National and Kapodistrian University of Athens Medical School, which has a national accreditation as a center of excellence for rare diseases cutaneous lymphomas. Professor Papadavid's main research interests are cutaneous lymphomas, skin oncology, and inflammatory skin diseases. Professor Papadavid performs clinical and translational research studies at the national and international level, and she participates in scientific committees in several grants in ProCLIPI International Consortium for Cutaneous Lymphomas, and is a national PI for ERTC clinical studies in cutaneous lymphoma. Moreover, Professor Papadavid is the author of 115 publications, and her work was granted by international prestigious awards such as First Prize in the European Congress of Photodynamic Therapy, First Prize in the European Congress for Cutaneous Lymphomas, and 3 first prizes at the national meetings. Professor Papadavid has been a member of ERTC Cutaneous Lymphomas Task Force with a function of a board member, treasurer, and a secretary. Professor Papadavid has been also a board member of the International Society for Cutaneous Lymphomas. And the second speaker, Pietro Quaglino, is an associate professor of dermatology at the Department of Medical Sciences, University of Turin Medical School, and the director of the residency program in dermatology at the University of Turin. His main field of interest for clinical and research activities are cutaneous lymphoma, melanoma, and immune dermatology. His experience in the field of cutaneous lymphoma ranges from the early diagnosis to the treatment of the advanced phase disease. He is the principal investigator of several clinical trials in melanoma and cutaneous lymphoma. He is a past chairman of the ERTC Cutaneous Lymphoma Task Force and has been member of the board directors of the International Society for Cutaneous Lymphoma and the board member of melanoma associations at the national level. He has published more than 200 peer-reviewed scientific papers. Professor Quaglino is assistant editor and the reviewer of national and international journals on dermatology and the referee for National Agency for the Evaluation of Universities and Research Institutes. Professor Papadavid and Professor Quaglino, the floor is yours.
Dear Julia, thank you very much for this nice introduction. And for myself and Professor Quaglino, we have agreed to split the presentation in two. So I will start with the first topic, which is the clinical and histological findings in aggressive T-cell lymphomas. Just a very brief introduction, and the primary cutaneous lymphomas are a variety of T and B-cell neoplasms that involve the skin primarily. And secondary cutaneous lymphomas are systemic lymphomas that secondary involve the skin. And the estimated annual incidence is 1 in 100,000. There's a completely different clinical behavior prognosis from the systemic lymphomas, and 65% of all primary cutaneous lymphomas are T-cell types. I will refer to this ERTC classification that separates lymphomas into the ones with the indolent clinical behavior and the aggressive clinical behavior. And as you can see, there are several types. Sensory syndrome has been already discussed before, and this will not be discussed in this webinar. And all the others will be extensively addressed. The adult T-cell leukemia lymphoma, the extranodal NK T-cell lymphoma, nasal type, the primary cutaneous peripheral T-cell lymphoma, unspecified, the primary cutaneous aggressive hematologic CD8 positive T-cell lymphoma, provisional, and the cutaneous gamma delta T-cell lymphoma. I will start with a very interesting type, which is the epithelial CD8 cytotoxic T-cell lymphoma, and which is characterized mainly by the proliferation of epithelial CD8 positive cytotoxic T cells and has an aggressive clinical behavior. It presents with eruptic papules, nodules, and tumors, and often these tumors show a central ulceration. There is visceral involvement, and especially with CNS involvement, but lymph nodes can be spared. It's a very aggressive disease with a median survival of between 2 or 3 years, and chemotherapy is anthracycline-based systemic chemotherapy, which will be discussed by Professor Quaglino. This is a clinical case of a patient with in our institution with CD8 positive aggressive hematologic lymphoma. You can see the nodule and the central ulceration, which becomes necrotic and filled with a crust. This is the same patient with infiltrated plaques showing central ulceration, necrotic areas, papules, and nodules at the same patient. And this is the histology and H&E, which you can see the epidermotropies in this case. Many of these T-cell, the malignant T-cells enter the epidermis, and this is a very characteristic histological finding of the epidermotropic CD8 positive T-cell lymphoma. And this is the immunophenotype that characterize the CD8 positive cells. As you can see, many of these cells are in the epidermis, lower dermis, and epidermis, and enter the epidermis. A very interesting issue is the differential diagnosis between the epidermotropic CD8 positive lymphoma, because this is a very rare and aggressive lymphoma, and we need to be sure that the diagnosis is correct before we consult the patient. Lymphomatoid papulosis type D is a fairly new described variant of lymphomatoid papulosis and can be confused with cutaneous aggressive CD8 positive cytotoxic T-cell lymphoma. And the reason I will discuss further this is that lymphomatoid papulosis is a benign lymphoproliferative disease, whereas a cutaneous aggressive CD8 positive cytotoxic T-cell lymphoma is a very aggressive form of cutaneous lymphoma. And this is a case described in a woman of 38 years old with an atypical infiltrate of cells, ecstatic in the dermis, massive epidermotropies, and the patient histologist immunophenotype was positive for CD8 and CD30. And this was diagnosed as the newly described type B variant of lymphomatoid papulosis. The patient didn't reveal any systemic involvement and remained well with no active treatment. Another publication on the same topic, recurrent course and CD30 expression of a typical T-cell lymphocyte distinguished lymphomatoid papulosis from primary cutaneous aggressive epidermotropic CD8 positive cytotoxic T-cell lymphoma, which are very important key points to take. On the other hand, there is another, the end of the spectrum, there is another condition called ulceronecrotic Mucha-Habermann disease. Is a form of PLEVA, acute pityriasis lichenoides and varioliformis acuta, but it presents with very profound systemic symptoms such as high fever, and the skin also has a clinical picture of ulceronecrotic papules, sometimes large ulcers with necrotic crusts. So in this, the end of the spectrum, cutaneous lymphomas of this type of PLEVA, of pityriasis acuta, may resolve lymphomatoid papulosis or even a CD8 positive epitopotropic T-cell lymphoma. And the differential diagnosis remains very difficult sometimes in very specific cases. And in these grounds, the CD8 positive phenotype and the CD30 negative phenotype distinguish between PLEVA, ulceronecrotic PLEVA, and lymphomatoid papulosis type B. Again, there are some exceptions in medicine, and there are some cases of PLEVA, ulceronecrotic PLEVA, that CD30 can be positive. And this is the case of one patient of ours presented with these very extensive lesions all over her body with severe symptoms, malaise, fever. She had splenomegaly, and she had these patches, plaques that ulcerated and became crusted. She had epidermotropic infiltrate, as you can see, with T cells entering through the interface, the epidermis. This is a close-up of the same histology. And at the same time, she had a lot of hemorrhage in the dermis, and these small T cells around infiltrating the dermis. She was serology phenotype was CD40 negative, as you can see on the right side of the slide, and CD3 positive. And this is the CD8 immune staining, which showed a very extensive CD8 infiltration. Going further to the rare cutaneous T-cell lymphomas, there is another subtype, which is the subcutaneous T-cell lymphoma, Fungoides T-cell lymphoma. This is a rare primary cutaneous T-cell lymphoma, and it's mainly an infiltration of CD8 positive T cells infiltrated the subcutaneous tissue. And there are two groups of this entity. The one group expressing the alpha beta T cell phenotype, which is the classic one, usually of CD8 positive T cells restricted to the subcutaneous tissue. There's no dermal or epidermal involvement, and this has an indolent clinical course. And the other end of the spectrum is a similar presentation with a gamma delta T cell phenotype. In this case, the phenotype is mainly CD56 positive T cells, where it is CD8 and CD4 negative. The difference between these two entities, apart from the indolent and the very poor prognosis on the side of the gamma delta T cell phenotype, is that there is epidermal and dermal infiltration on the gamma delta T cell phenotype, subtype of subcutaneous T cell Fungoides. So the QRTC classification uses the term subcutaneous Fungoides when it refers to an alpha beta T cell phenotype, whereas the cases of the gamma delta T cell phenotype are separately classified as cutaneous gamma delta T cell lymphomas. And this is the schematic distinction between the alpha-beta T-cell receptor chain of the receptor and the gamma-delta chain. And again, there is a detection of alpha-beta chain in the benign indolent form of subcutaneous folliculitis, whereas the other forms expressing gamma-delta belong to the subtype of the gamma-delta lymphomas. This entirety constitutes only 1/4 of the subcutaneous folliculitis T-cell lymphoma cases, and as I mentioned before, has a very extremely poor prognosis. There are multiple subcutaneous nodules with ulceration necrosis are seen mostly on the extremities. There are pancytopenia, and 1/3 of the cases can be complicated with hemophagocytic syndrome, and also with jaundice and other severe systemic symptoms and organ failures. The median survival of this entirety is almost 1 year. On this ground, I will present 2 cases of gamma-delta lymphomas, and I would like to show that there are some exceptions, and this is a very big, again, spectrum of disease. This is a 57 years old male, which has been confirmed with MF, plaque stage, initially like 4 years ago, when he started with skin-directed treatment. Then he continued to have progressive skin disease, and the histology, the histological diagnosis was more of a gamma-delta lymphoma of a superficial type, which, as we will see later on, can be sometimes difficult to distinguish between an MF of a gamma-delta phenotype. And he was treated by an hematology department in a different hospital by chemotherapy and different other treatments. He visited our department almost 1 year ago, and he had these plaques on his abdomen, lower legs, upper legs, and some hyperpigmentation from previous treatments. And it was very difficult to diagnose between an aggressive T-cell lymphoma of gamma-delta phenotype or an MF of gamma-delta phenotype. Again, as you can see in this patient, we could see some patches, plaques, and the initial histology was more favoring MF of a gamma-delta phenotype, which was due to the absence of large size cells, according to the pathologist. And again, both of these conditions can have an extreme show epidermotropism, on a typical lymphoid infiltrated on the epidermis and the dermis. And I would like to stress on the high KIS-T7 index found in this patient. And this is the histology. You can see the dermis and the epidermis infiltrated by typical cells in the dermis, the epidermis. And the CD56 expression was negative, where the CD8 expression was positive. Excuse me for that. I could show the CD8 positive expression, but I don't know why it's not shown in this, on my screen. And the expression of TCR gamma cells was also positive. I'm sorry, I apologize, but the slides were not shown on the screen. Based on our findings and the differential between MF of a gamma delta phenotype or a superficial type of gamma delta rare epidermotropic lymphoma, we decided to proceed with skin-directed therapy of total skin electrobeam. He got a very good but partial and short-term response. We proceeded with the Tenfero, pegiterferon alpha 2A, and he presented with side effects and progressive disease. And his plaques were getting more aggressive, and he started with necrotic also plaques and ulcers, and involving the lower legs, also the palms and the soles. And he was referred to our special cutaneous lymphoma unit, where we see the patient with hematologist and therapist. And the new biopsy was favoring more an aggressive lymphoma, and as he did not respond to several therapies, the patient was treated with monotherapy, and then he is planned for an allogeneic hematopoietic stem cell transplantation with the diagnosis of a gamma delta rare aggressive T-cell lymphoma. Although his disease has been on for almost 4 years now. And on the other hand, this is a case of a female patient with multiple subcutaneous nodules. She was physical examination. She was found to have multiple subcutaneous nodules on her right trunk and thighs. And histology was indicated a primary cutaneous gamma delta lymphoma involving only the subcutaneous fat, and this was negative for CD8 and CD4. The dermis and epidermis were not treated, and after a complete workup with the CT scan, bone marrow biopsy, and etc., she was found to have no extracutaneous involvement. I apologize, but we can also see only see the T cells, the CD3 positive T cells in the subcutis. And I'm afraid you cannot see the other histological pictures of the dermis and epidermis, which show there was no activation of typical T cells. And the expression of TC gamma T cells, where she was negative for TCR alpha beta cells. So based on this histology and the clinical chemotherapy, and she was examined regularly on the specialized center for cutaneous lymphomas. By surprise, she had an excellent and an eventful course lasting for 6 years until she developed new subcutaneous nodules, which were proven to be new disease. And she had a complete workout, and we still follow this patient once a year. In support of what I presented, the two cases of gamma delta lymphoma with not very aggressive course, mimicking mycosis fungoides of gamma delta phenotype, and a gamma delta subcutaneous folliculitis type of lymphoma, which had an indolent course. There are other cases in the literature showing that gamma delta may not be all the time aggressive. As you can see, female patient with disease with bad prognosis, but a male patient with similar subcutaneous lesions, but with uneventful and good prognosis. In conclusion, primary cutaneous T-cell lymphoma showed gamma delta phenotype and epidemiotropic pattern appear to have a better prognosis than the typical panniculitis gamma delta T-cell lymphoma. And sometimes it's difficult to differentiate between this gamma delta with epidemiotropic pattern and MF with gamma delta phenotype. Primary cutaneous gamma delta lymphoma is rare and aggressive, with 11% of the patients achieving the 5-year survival. However, as mentioned before, there are a few cases associated with a more indolent course. Expression of gamma delta can be found in classic MF or lymphomatous papulosis, and this may suggest that there is a better course, and identification of gamma delta phenotype in a case clinical histologically resembling MF requires a close follow-up of this case and awareness of a potential aggressive behavior. And for primary cutaneous gamma delta T-cell lymphoma, histological analysis usually displays an atypical infiltrate involving the epidermis, the dermis, and the subcutis. And immunohistology typically displays a TCR gamma positive phenotype to larger size cells with a variable expression of CD56. There is a trend of favorable outcome in our patient that had the subcutaneous fat involvement, which is rare for a gamma delta subcutaneous panniculitis, gamma delta lymphoma. And as I mentioned before, there are other cases reported in the literature. The adult T-cell leukemia lymphoma is a rare neoplasm caused by a retrovirus infection by the HTLV1. It's endemic in specific areas and characterized by a large number of circulating atypical cells. Skin lesions resemble mycosis fungoides histologically, can be undistinguishable. And the neoplastic T-cell expresses CD3, CD4 positive phenotype. CD25 can be highly expressed, and that can be divided to acute and chronic types. As you can see, the acute type skin lesions can be nodule tumors, plaques, and papules, similar to those found in mycosis fungoides. Again, we can find enlarged lymph nodes, bone lesions, and prognosis is poor. And chronic HTLL skin lesions also resemble mycosis fungoides. Circulated epithelial cell can be absent, and is a more indolent clinical course and a better survivor. The extranodal NK T-cell lymphoma nasal type is more common in males, is more commonly seen in Asia, South America, Central America. It's a Epstein-Barr associated lymphoma, multiple plaques, tumors of the trachea and extremities, and in the nose and nasopharynx. Systemic symptoms can be present. There is an association with the hemophagocytic syndrome. The malignant cells are usually CD56 positive, the NK cell phenotype, and Epstein-Barr virus also positive. It's a very aggressive disease with a minimum survival of less than a year. And finally, the primary T-cell lymphoma unspecified is a heterogeneous group which includes all T-cell neoplasms that do not fit on the predefined subtypes. All of these cases, a diagnosis of MF must be ruled out by complete clinical examination, accurate clinical histology, and I will briefly summarize a recent publication by the ERTC Cutaneous Lymphoma Task Force Group on the clinical, pathological, and prognostic features of this heterogeneous group. 33 biopsies were studied in a series of several workshops and by experts. There was a male predisposition. The median age was 66.5 years old. Most of the patients had a disseminated papules and nodules compared to solitary nodules and tumor plaques. And mostly, when present, the solitary tumors were located on the lips, particularly on the legs. And prognosis was bad and independent of the T stage. Histology was characterized by primary malinfiltrate with involvement of the subcutaneous tissue. And in 40% of the biopsies, there was a focal mild epidermotropism. I apologize, there was a picture of this showing the depth of the infiltration. And there was a variation of the tumor cell size with predomination of medium-sized to large tumor cells with an clear pleomorphism. And the tumor cell size was identified as a prognostic factor. There was a lower 5-year survival for tumors with large cell morphology compared to those with a medium-sized tumor cells. And there was also subcutaneous involvement by the immunophenotype of the subcutaneous involvement was mostly of CD4 positive or W negative. There were also other unusual phenotypes found, and there was overexpression of CD20 positive cells. And as you can see here, the CD4 positive was mainly seen in the disseminated type of lesions, which account for the 70%, as mentioned before, of the cases. And also, from this very interesting paper, there is another piece of information that solitary tumors displayed a high level of GATA3 expression, as you can see. Closing this first part of our presentation and giving the next talk to Professor Quaglino on the treatment, I would very shortly summarize on this paper by the ERTC Cutaneous Task Force Group on non-otherwise specified primary T-cell lymphomas, and for solitary tumors, the surgical excision and radiotherapy was the most appropriate first-line treatment chosen by most of the dermatologists. Chemotherapy was less frequently seen in solitary tumors, and most of the patients had chemotherapy as a second line. Most of the patients with disseminated lesions had chemotherapy and second line radiotherapy. And most of the patients died of lymphoma, and these patients had received chemotherapy. And there is a question if this is a regressive therapeutic approach in these patients, and if patients with single lesions should effectively be treated with radiotherapy, surgical excision, or more aggressive treatment. And there is a need for more effective treatment strategies. So this is the end of my presentation, and I will finish here and ask Professor Quaglino to continue with the management.
Yes, thank you, Leah. Good afternoon or good evening to everybody. Here in Italy, there is still the sun. Hope also in your countries. It's a pleasure and honor for me to be here, and also many thanks to Leah for the first part of the presentation, and also for introducing my topic, which would be today treatment of these aggressive cases. Before starting my presentation, I would like to thank so much Julia, all the meeting organizers, and the friends who lead the project of the EuroBloodNet, and particularly all of you who are here and listen to our presentation. I hope that you could see my screen. I will start my first slides. So I will focus on clinical management and treatment data, and this topic represents definitely a challenge due to the lack of literature data, evidence of active treatments, and also rarity of these diseases. These are my conflict of interest, and I would like to start my presentation by focusing on two main points. Already Leah highlighted this, but it's important because they represent the starting point for evaluating our treatments. So these are a group of diseases characterized by two main features, very rare, so frequency among primary cutaneous lymphomas around 1 or 2%, but definitely a very poor prognosis with disease-specific 5-year survival of 10-20%. Even if, as you have learned from Leah's presentation, there are different entities, as you see in the first column, the synodal NK T-cell lymphoma nasal type, the gamma delta T-cell lymphoma, the CD8 epidermotropic aggressive lymphoma, and the primary peripheral, not otherwise specified lymphoma. The approach for the treatment could be considered roughly the same, given the extent of disease involvement in the skin and also potentially extracutaneous involvement. You see also in the last line another entity which shares with the previous one the rarity and the poor prognosis, and this entity was designated with different terms in the past. As you see, blastic NK cell lymphoma, CD4, CD56 hematodermic neoplasia, reflecting different hypotheses about the origin from NK precursors, but now it's called the plasmacytoid dendritic cell neoplasm, highlighting the origin from myeloid precursors. And indeed, this is important because for this disease, it's better chemotherapy as a chemotherapy approach as performed in acute myeloid diseases rather than T-cell lymphoproliferative disorders. Okay, we talk about poor prognosis, and this is indeed related to the widespread ulcerated plaque tumors and also frequent extracutaneous involvement. But we have to share and to stress the point that in the vast majority of these patients, we are dealing with widespread lesions, so solitary or regional, very rare cases. In the majority, there are widespread ulcerated nodular lesion with a great severe impact on the quality of life. So definitely for all these reasons, these patients represent a subset with high clinical need of effective treatment. So what can we do for these patients after the diagnosis? First of all, very important, clinical staging. We as dermatologists or clinicians need to perform an accurate staging starting from the definition of the involvement of the skin using the categories T1, T2 or T3. T1 is solitary, T2 regional, T3 generalized. But as already told to you, in the majority of cases, these patients show a T3 generalized skin involvement, or if they present with T1 or T2 rapidly develop more disseminated skin lesions and tumors. But anyway, it's important to collect this data. And also, it's very important to adopt an accurate staging for extracutaneous involvement, including CT scan, PET CT, and also bone marrow biopsy, just for two main reasons. First of all, because we have to confirm or exclude the primary cutaneous origin of these diseases, because in these cases, skin could also represent the localization of lymphoproliferative disorders, which originates from lymph nodes, so are not primary cutaneous lymphoma cases. And the second point is that in case of primary origin, it's important to detect during follow-up extracutaneous involvement, which is unfortunately frequent and associated with a poor prognosis. For all these reasons, and this is the third point, but it's very important to consider that for these patients is fundamental a multidisciplinary approach, and thus we need a multidisciplinary team to take care and to treat and to follow these patients, including dermatologists, hematologists, radiation oncologists, or radiotherapists, as we call these people in Italy, pathologists for sure, molecular biologists, nurse team for skin care, and all the other specialists that can be involved, considering the different involvement of organs and tissues. So it's very important to allow a correct management of these patients. What about treatment? The most frequently used treatment modality is represented by chemotherapy. However, very few and scarce literature data can be found specifically focused on chemo results in these rare primary cutaneous lymphomas. Usually we can find some patients treated with chemotherapy with peripheral or CD8 aggressive, or included in mycosis fungoides patient cohort, or more frequently associated with patients with non-primary cutaneous lymphomas. And that's the reason why in these cases treatments are motivated from hematologist indication. That's also important to consider again and to highlight the relevance for multidisciplinary approach and collaborations, in particular with the hematologist. What can be considered as a general consideration while talking about chemotherapy? As you know, we can use monochemotherapy or polychemotherapy. And as general, for advanced cases of cutaneous T-cell lymphomas, this is historical but not so recent literature review. You can see that polychemotherapy can induce potentially higher response rate. You see 80% instead of 60% with respect to monochemotherapy. Complete responses are low and generally similar, but what is more important is response durations is, in the large majority of cases, very short, and you see some months median duration without an impact on the clinical course of the disease. Coming to more details, which are the regimen that can be used considering chemotherapy. Considering polychemotherapy, more commonly used are CHOP or CHOP-based regimens. In particular, as I will show you, CHOEP, so CHOP plus etoposide. Whilst considering monochemotherapy, there are results with gemcitabine, with purine analogs, or with pegylated doxorubicin. With response percentages, you see ranging from 60 to 80%, but I have to say that in the majority of cases, these studies are not focused on these rare aggressive T-cell lymphomas, but includes also other advanced cases of mycosis fungoides or other hematological malignancies. And this other cartoon shows better in detail the problem of remission, duration, and time to progression of progression-free survival, as you see here, with median durations reported of only a few months. So even if there are responses, these are short-lived, and there is frequently a relapse. And I will show you in more detail some papers, just also to show you how literature data on these rare aggressive T-cell lymphomas are reported. This is an example of an Italian multicenter study with gemcitabine published some years ago in Cancer. And you see here a small patient cohort. Majority are mycosis fungoides, only a few cases are peripheral T-cell lymphoma, so even difficult to get some insight from these data. And you see here that there is an interesting percentage of responses, also complete responses, 20% in these 5 patients. And you see here progression-free survival and overall survival showing the disease course after this treatment. I mentioned before CHOEP, and there are representative data coming from retrospective studies, and this is an example on hematological patients that suggest a higher activity of CHOEP, so CHOP plus etoposide with respect to CHOP. The problem for sure for polychemotherapy is that even if we can get responses, these are short-lived, and the problem is that we are dealing with frequently old patients with comorbidities, and this is an important point because you know that polychemotherapy is associated to severe toxicity, myelosuppression, hematological toxicity, and is an important issue to consider in this patient. Anyway, this data seems to suggest a higher activity of CHOEP with respect to CHOP. Also consider that etoposide has been historically associated with a good clinical responses in the skin. So the association of etoposide with CHOP could be a good option in young patients with skin involvement to get a higher activity for these treatments. And besides CHOP, there are also some data published on chemo combination, including even higher number of drugs. This is an example of VCOB-BIS in a publication from our center some times ago. Again, small patient cohort, only some patient with peripheral, what's called pleomorphic lymphoma, good percentages of responses, but short time duration, three months. So another important option to be considered for this patient is for sure allogenic transplant. You know that is a relevant procedure which underlines against the importance of multidisciplinary approach in the team, which is used not only in these cases, but frequently in advanced cases, mycosis fungoides and Sézary syndrome. And in these cases, we have relevant data coming from European collaboration that suggests that this treatment approach in selected cases can be considered as a very relevant and active and effective opportunity for treatment, given the possibility to induce in a selected percentage of patients good remission during years. So I have to say that in these cases of aggressive disease, the possibility to undergo allogeneic hematopoietic stem cell transplantation need to be considered since the first step of the treatment, and that's important again, the collaboration with hematologists, and for sure we have to take in consideration the age is important, comorbidities, and for sure the possibility to have patients with a good remission and the disease under control, and that's a point is very difficult with with the treatment option that we can have. I would like just to share with you this recent review and meta-analysis of all the published studies in cutaneous T-cell lymphoma overall. So majority would be mycosis fungoides, but also these cases, and the authors included 5 studies published in different years. And this review, what is the message? Identified percentage of overall survival rates of 59%, which is good considering the majority of these patients had advanced refractory disease. However, with progression-free survival rate of 56%, so potentially risk of disease relapse even if after allo transplant. So which could be a comprehensive scenario for these patients? I will try to summarize what has been, what can be derived from literature and personal experience. Independently from the diagnosis, in case of this aggressive cutaneous T-cell lymphoma, the approach through a multidisciplinary team, chemo, potentially poly with CHOEP in young patients at a wide evaluation on the basis of age and comorbidities, and allotransplant in patients that can undergo this procedure and have this disease under control. Selected patients with solitary or regional lesions can benefit from radiotherapy, which is a treatment that can also be used in patients with good partial response to obtain a complete response to improve response. And for sure, for all these patients, important clinical trials when available. And this is a good cartoon showing the treatment algorithm for blastic plasmacytoid dendritic cell neoplasm. I don't have time to get into details, but definitely it represents these options. So chemo for young patients, polychemo, otherwise low-dose chemotherapy, transplant in responding patients. So last slides of my presentation for future perspectives. We are living in a period where we had the possibility to have clinical trials specific for our mycosis fungoides and Sézary syndrome patients. And this was the possibility to have new drugs available and also a variety of trials ongoing or completed very recently. And this is a cartoon showing all the recent trials ongoing or not in primary cutaneous lymphomas, mainly mycosis fungoides, Sézary syndrome. And I have to say that only a minority of these patients of these trials included also this aggressive non-mycosis fungoides treatment. I would say only one, this bortezomib with NF-κB inhibitors in a very small number of patients. So for sure, we are waiting for new clinical trials in these patients. I found a couple of cases published in literature who report the activity of brentuximab vedotin in these cases. And for sure, we can use these options in the presence of CD30 positive expression, and could be the possibility this drug is approved and reimbursed also in Italy generically for cutaneous T-cell lymphoma CD30 positive, so it could be a good option. And there is also clinical trials ongoing with this drug, which is an anti-human CD30 monoclonal antibody called FMM13. And this is the study Redirect, which is a phase 2 study including advanced cases mycosis fungoides and relapsed or refractory CD30 positive peripheral T-cell lymphomas, which is now enrolling in our center, so it is a good option for these patients. Last but not least, this is a new treatment option for blastic plasmacytoid dendritic cell neoplasm, which is this drug, which is called the tagaraxofusp, is a drug which is directed against the receptor of IL-3, which is constitutively expressed on the surface of these cells, which is CD123, and the binding of this the antibody with the ligand induces the internalization of the true drug, which is the translocation domains of diphtheria toxin. Like we had a drug in the past, ONTAC, not available in Europe, which had a similar mechanism of action. This is a new drug reported in New England Journal of Medicine last year for this patient, allowing good remissions and also with potentially interesting remission duration. This is my last slide, just to show you that my town Turin is not cutaneous lymphomas, but is monument, history, some fun and drinks and food in spite of the nightmare of the COVID pandemic outbreaks that we are experiencing and we had experienced in the previous time. Thank you so much.
Thank you, Professor Papadavid, and thank you, Professor Quaglino, for this great and comprehensive presentations. And now I kindly encourage the audience to ask direct questions in the chat.
There is a question.
Oh, a question.
Okay, which cases with? Okay. I think that with regard to the question from Julia, what do you think would be future directions? I think that generally we need clinical trials for these patients. It's difficult to run these trials only with these cases because they're so rare. So in association with cases with hematological counterparts, if possible, or other cases like in the basket trials. I think that we are waiting for results from molecular alteration. So we are living in a time of precise medicine. So I think that we need like CD123 other targets option for this treatment, and why not to have the possibility to consider also immune therapy activity in these cases. Okay, I don't know. Yeah, there's a question on ATL. I think that, for example, I very rarely had the possibility to treat this patient. I remember 2 or 3 cases. I discussed this with hematologists, and in all these cases, the option was treatment, and they received treatment in the hematological department.
I agree. The same with me too. These cases are usually handled by the hematologist because of the nature of the disease. There's another question for me. The gamma delta lymphomas not being very aggressive, can we separate them from the aggressive histologically? Well, it is difficult to separate them histologically. The only, as I mentioned in my lecture, there is a spectrum, and the gamma delta that are more epidermotropic, they look to have a more indolent course comparing to the ones that have a subcutaneous involvement. However, as I mentioned, the patients that have very rarely have a more indolent course, even if they have the subcutaneous phenotype. The involvement. The Ki-67 index is, I think, one a gross index for us to know if these lesions are proliferating very quickly. So in cases that we see this Ki67 index high enough, I think this shows that this is a more proliferative disease, and to treat accordingly.
Okay, I can see other two questions on transplant. Would you consider myelodiabetic condition aggressive? Okay, I mean, all these cases are discussed with hematologists. As you mentioned, in the majority of cases, like mycosis fungoides is used a reduced intensity regimen. But remember, one specific young patient very recently that had very widespread lesions and was decided to use a myelodiabetic conditioning regimen in this specific patient. But again, we don't have any, I mean, shared and homogeneous regimen to be used in these patients. And thanks, Robert, now to Professor Nobler for this question. For sure, photopheresis can be used after bone marrow transplantation also to control GVHD. And for sure, this can be an important point. I don't have in mind any case of aggressive T-cell lymphoma specifically treated with photopheresis for the skin lesion of this patient. I don't. And the last question, I don't have experience on this treatment, but for sure could be another important future direction to use hypomethylating agents or HH inhibitors to check and to target epigenetic mutations. But if some of you have specific experiences also from a hematological point in hematological disorders, will be very, very important, and underlines the importance of working together, because we can translate regimens used in nodal lymphomas to treat these cases when presenting primarily in the skin.
Yeah, I agree completely. This is a very good suggestion for
particularly peripheral T-cell lymphoma, because for sure gamma delta or CD8 positive, there's no counterpart in as hematological disease, but peripheral T-cell lymphomas, otherwise specified, can present primarily in the skin or in other lymph nodes or extracutanous sites.
Thank you very much, Professor Papadavid and Professor Quaglino. And thank you, audience, for this great session and discussion at the end. And before we go, I have some information. So please do not forget to fill in the survey we will send you after this webinar. As I said at the beginning, it's very important for accreditation. The next session will take place in October. So please double check whether you're subscribed and you registered for this session. And of course, I would like to invite you to also subscribe to our newsletter and follow us on Twitter, LinkedIn, and Facebook. And please visit us at EuroBloodNet's Edu YouTube channel, where we publish all of the webinar sessions. Thank you very much, Professor Quaglino and Professor Papadavid.
Many thanks to all of you for the organization, the involvement, and to all the people who were with us today and listened to our presentation. It was a great pleasure.
I would like to thank you very much also for the organization and for all the participants, and thank my friend Professor Quaglino for such an interesting presentation.
The same for me. Many thanks, Papadavid. It's always a pleasure.
Thank you very much, everybody, and see you next time.
Thanks.
Bye-bye.
Bye-bye. Thanks, everybody.